Hi, my name is Carrie Bogiagis, and I am a physical therapist at the Foundation for Blind Children in Phoenix, Arizona. I have worked at the foundation for, this is my 18th school year, and it's in August, I will be a physical therapist for 25 years. So today, the topic of conversation, is the impact of vision loss on motor development. I was interested in knowing who the audience would be, and because of those of you who RSVP'd, I was able to get a list and see that there are TVIs, O&M specialists, therapists, teachers, a really nice group of people. The objectives of today's presentation is that participants will be able to state examples of how having a visual impairment affects motor control, and state strategies to assist motor development with children who have visual impairments. The agenda, I just want to give you an overview of the things that we're going to cover. At first, I will go over what I mean by fine and gross motor, and factors that affect motor development due to visual impairment, the relationship or interaction really between vision, sensory experiences, and motor development and control, fine motor and self-help skills, and then give you some strategies that you can use and take home with you from this presentation. And then I want to talk about motor development as it relates to specific visual impairments, cortical visual impairment, retinopathy of prematurity, and optic nerve hypoplasia. So the Foundation for Blind Children is it's a large nonprofit organization, and we're called the Foundation for Blind Children, but we really do work with kids from birth up to adults, even over the age of 100. We have different areas in our different departments. We have a low vision clinic, there's a school, we have an early intervention program, an adult program. So we really do work with students, clients, babies, adults through the lifespan. The gross motor skills. Gross motor skills use the large muscles of the body, so the arms, the legs, the trunk, and it can often be described in three different ways. Locomotor is moving through space from point A to point B. So this refers to rolling, crawling, pulling up to stand, walking, running. Stationary skills, gross motor skills, really when you're not moving in space, but you're holding your head up, you're sitting, you're standing, you're tall kneeling. And then object control, we often think of a lot of ball skills, throwing, catching, throwing underhand, throwing overhand, kicking a ball straight, throwing at targets, skills of that nature. And fine motor skills are the movements and coordination of the small muscles of the body, and we're typically thought of as the movements that involve the fingers and the hands. And these are important for supporting independence with dressing, feeding, eating, functional play skills, handwriting, dressing, and performance in school. So a group question that I like to ask, if this were a live webinar, is how do you think vision loss affects motor development and why? Well, we're going to go through and answer that question. Incidental learning. This is a big deal. Incidental learning refers to any learning that is unplanned or unattended. It's believed that 80% of what children learn comes to them through their vision. So incidental learning, we learn by watching how someone throws a ball overhand. We learn by, I would ask you to rock a baby or demonstrate how to rock a baby, and I'm sure no one explained it to you, but you've watched people how to do that. The School for Foundation for Blind Children and the different parts of the department and other schools, they are so important because a lot of the skills that sighted people learn through incidental learning have to be intentionally taught to the students and children as they develop. There's a story that a teacher told me years ago when I first started at Foundation that I still remember very clearly, and it really hit home the idea of incidental learning and really giving the students and children time to explore. She told me that she's an orientation mobility specialist, and she asked a 7th grade student what a car is. And she said, "It is a moving couch." That just kind of stopped me and made me think, oh my gosh, her only experience with the car was opening the car door, sliding in, and sitting on a bench seat that felt like a couch, and then it moved. So the lesson that day was to explore the whole rest of the car and recognize that that seat was part of a bigger item or object and how it all fit together. There was a seminar here or a in-service program. Oh gosh, I don't know what I'm saying, like a conference, sorry. And this TVI, teacher of the visually impaired, gave an example in one of the courses where she had mentioned that one of her teenage students went to the store and had asked where she could buy the toast. So she just hadn't realized that there was a process from bread to making it toast. So there's just a few examples, not necessarily motor related, but incidental learning is the lack of incidental learning is a big deal. So I just want to refer to this pyramid. Academic learning is at the top, and you'll notice there are a lot of sensory systems at the bottom: tactile, vestibular, visual, auditory, proprioception, and then taste. We're already going to cross off visual, put an X through that, because we already know we're talking about how having a visual impairment affects motor development. So keep this pyramid in mind as I continue to talk, and we'll reference back to it. Vision is the primary motivator for movement. Sound is a distant second because that comes later on. Do the babies and the infants have to understand what the sound means to determine if they're motivated? So gross motor skills, we know they're already delayed because of incidental learning. Now we just mentioned that vision is being the primary motivator to move. So with a lack of vision, you might see decreased movement. And also children may not be aware what is outside their reach. So maybe they're not motivated, or they're just not aware that there's something there that they may interest them. They may have fear of movement. So they may have moved outside of space or have an insecurity of moving and may have had not a good experience, or they're just unsure of moving out of their small area. And then there may be protective guardians. I think guardians and parents are very, very well intended, and we really have an opportunity to share with them how wonderful and exciting it is and important that they provide opportunities for their young kids and their babies and children to move and to have expectations rather than doing for them. The delay that we see is typically in self-initiated movements. Not so much in the stationary gross motor movements that I had talked about and referred to earlier, such as standing and sitting in one place. Self-initiated gross motor movements are the ones that are on this chart, but it's rolling, crawling, laying down to sitting up, pulling to stand, walking. Those are some examples. And gross motor development, this is typical gross motor development chart. And the kids that have vision loss, they typically still develop in a linear fashion, meaning in a certain order, but it is delayed by a few months. And this is if there's no other diagnoses besides vision or vision loss. So this is sort of how everything, vision, sensory, and motor all tie together. I realize that vision is one of the sensory systems, but in this case, vision is going to sort of kick off a chain of events, and you'll see what I mean. So if we have a lack of vision, a baby is born and has decreased vision, we can expect most likely that there'll be decreased movement. That decreased movement results in limited sensory experiences. The limited sensory experiences affect our muscle tone or body awareness. And then that affects gross and fine motor coordination and the quality of movement. So those sensory systems that I'm referring to are tactile, which is our sense of touch, vestibular, which is sense of movement, and proprioceptive is a sense of where our body is in space. During the first year of life, a baby learns many motor skills through the information provided by tactile, kinesthetic or proprioceptive, and vestibular systems in response to visual and auditory input. So really, we talk about sensory motor, we hear that a lot, right? So we bring in information through our senses, and then we have a motor output. But the information coming in from those senses is helping us modify and moderate our movements. So sensory and motor control, the sensory systems guide and organize motor control. Sensory information is used to detect and correct errors in the accuracy of movement. So if I overshot or overreached or overstepped, or maybe I used too much force. Vision provides continuous information for the position and lack of body segments, or excuse me, the location of body segments in relation to the environment. And the lack of visual input impairs the visual feedback from movement. So we use our vision to help, modify and coordinate our movements. So sensory seeking and avoiding behaviors. This is not uncommon to see, and this typically results from lack of opportunity to develop, process, and integrate senses. And so these are just a couple examples, but our kids may seek input in a way that they're capable of. Rocking back and forth, shaking their head, banging hands together, mouthing objects, or maybe they're avoiding behaviors. Tactile aversion. In this picture here, you can see a toddler standing on his toes, not wanting to put his foot down on the surface. Auditory sensitivity, or people not wanting to put their hands in certain sort of, or babies in certain sort of mediums because they're not sure what it is. And then there are some people who are insecure about being on swings or moving through space. So if we refer back to the pyramid now that we had taken a look at earlier, visual sensory system was affected. And now, based on the last couple slides, what we just talked about, tactile is affected, vestibular is affected, and proprioception is affected. So 4 of the 6 foundational skills that lead up the top of to academic learning with motor planning in the line right above is affected. And that's the foundation for this learning pyramid. Auditory is on here, and some of our kids do have a dual sensory loss, so they have a hearing impairment as well. So what do we do? What do we do about all that? We're going to get to some strategies a little bit later on in the presentation. So I'm going to move on to fine motor, and what I'm about to share should sound very familiar because it's the same and similar reasons. Why gross motor is delayed is why fine motor is delayed as well. So they may be delayed to lack of incidental learning. In this case, watching how other people eat, watching how they brush their teeth, learning how to dress, where you put your cup down on a tray or on a table. Lack of visual motivation to reach. If they're not sure what's there, if it's motivating, there may not motivate them to reach out to touch different things. Lack of vision to assess what the baby will be exploring. So, may not want to put and reach out something that you don't know. I don't want to put something in my mouth if I can't visually assess it. So that's something to consider. Limited movement affects upper extremity strength. It's really important when the babies are developing that we encourage movement, and definitely crawling. Any kind of movement when you're prone on your elbows, and then you're pushing up through your hands, and then you're crawling on your hands and knees. You're building up the strength in your hands and then in your shoulders, and then also with your core. And then the limited sensory experiences affect the movement, the quality of movement. So fine motor use, I say upper extremity use, I say UE use, that is upper extremity use. And there's this baby here in an ATNR reflex, asymmetrical tonic neck, ATNR, asymmetrical tonic neck reflex. And you have to say, I have to say the body's pretty amazing, because if you turn your head, the face side faces the hand. So it's the first opportunity to recognize that the hand is part of their own body. And they really do need to learn that their hand is connected to them. And that you'll see that the kids will put their hands in front of it and turn it and eventually recognize that they're one in control of that. And I mentioned that crawling is important for strengthening. something in the therapy world we hear all the time. For those of you who aren't, maybe you have heard it before, but proximal stability for distal mobility, which means we need stability of the shoulders. We need stability of the hips if we want our feet or our hands to have fine movements. We've got to be stable up here and strong here for the mobility down here. And then limited sensory experiences affect motor control. I did say that on the slide before, so I must think it's very important for you to remember. So what are we going to see? We're going to see delayed milestones in grasping and reaching, in finger dexterity, which is the ability to handle like things within your hand or your palm, like a math manipulative, be able to use controls or turn a faucet, managing buttons, coloring in small lines, things like that. And then self-help skills. The self-help skills is these delays, well, in all of these things, a combination of incidental learning. A lot of these self-help skills we learn by watching others. It can be the lack of the sensory system, not having the fine tuning of their hands and being able to do the buttons and holding the toothbrush properly. And it could be due to like a tactile aversion, not wanting to put the toothbrush. So there's a combination of reasons, but typically hygiene, self-feeding, and dressing can be affected. So it's really, really, really important to support infants effectively during the early critical periods. I put a little thing on here with 4 hands, image with 4 hands, and it is kind of an all hands on deck situation that we want to make sure that a PTOT or anyone that has some input can be consulted at the very least to make sure that some of the strategies we're going to talk about get implemented early on. Joanne Szabo is a physical therapist, a local one, and she spoke at an in-service or a conference here at FBC. And unfortunately, I didn't get to see it, but I was able to get the PowerPoint slide. And I like how she worded this here. They, meaning babies, perceive the world differently. It is just not vision, but all that vision influences that infants and children are deprived of, affecting spatial, motor, and social domains. So it's not just a lack of vision, it's all of the other thing that it affects. And it's sort of a feed-forward snowball effect. So what do? Now that you know all the reasons or some of the reasons, and it's a combination of many that affect our motor skills. So some general ones are be sure to encourage movement and exploration. So if you're the one working with the families, demonstrate that it's okay, encourage them. It's really, really important that the kids have time to explore because they can't visually assess it. So as they're developing that, we really give them that extra time to take their time and explore. But we want to be mindful of over-assisting. Are we handing them everything or are we expecting them to move towards something? Are we handing it to them or are we asking them, we're putting a little bit out of their reach and then talking them through it or giving them cues on how to reach for it? We highly recommend that you use hand under hand assistant, we meaning foundation and most providers, probably all vision providers, that the child has more control and is more of an active participant. If we reach out and grab someone's hand and put it in, there's a protective response, and it's going to win that retraction or fear movement, and then the session won't be productive at all, or whatever activity you're working on. And then PTs say this all the time, but limit timing carriers or the containers as they're described to be, but the infant car seats or the little bouncy seats, bumbos. That's for a different reason. I shouldn't have outside the scope of this. But we want to make sure they're having the opportunity to get the sensory experiences and movement opportunities. So movement, even when the babies are young, little, and they're not moving on their own, we want to encourage families to encourage them to frequent positional changes, to change the baby's position throughout the day. So they're used to being in different orientations. And then have the guardian or the parents hold and rock, dance, spin with the baby. Moving through space, like in a stroller. Tummy time is really important. There are a lot of websites that you can look up tummy time, and they'll give you different ideas than just laying flat on the floor, maybe laying on a parent's chest that's raised up on an incline. But there's different ways to incorporate it through your day. Help a baby roll to get used to movement. So this would be assisted rolling, and maybe even have different textures, like a towel here, a different carpet here. And then you can use environmental boundaries. So a child might feel safe. So they're like, you could use towel rolls. I've seen some kids age appropriate playing in a laundry basket. So they have that boundary of where their toys are and where they are in space. As far as reaching strategies, we already talked about hand under hand, but it's very, very important. No forcing touch. Provide a structured play space. And then use cause and effect toys. First, we're going to find out if the cause and effect toy with the lights or the music is a good choice for the particular child. Typically, light up toys, if kids have some vision, is, but we don't want the toys to be too complex. So I have a picture here of a shelf with many cause and effect toys. That is a very busy shelf. So you just want to use one at a time, and maybe even something simpler at first where there aren't so many choices of colors. The toy bar on the left, this one has balloons on it, but you can hang anything on it. Different kind of tinsel or different objects. And the nice thing about the toy bar is if they hit it, it'll move, but it'll come back. So it's predictable. It's going to return. Also, movement for the kids who have cortical visual impairment is often helpful for them to catch their vision. The middle room, or the middle picture, is called a little room. So it has boundaries. It's a mat that's on the bottom, and then different things are hanging, items are hanging from it. They're always going to be in the same spot. So the kids are within environmental boundaries where they're reaching and kind of at their own time and at their own speed. So in the live webinar, I did ask for people to share their additional strategies, which was very helpful. A couple of them were wait time, blackboards, a lot of ones that we could use with kids with visual impairment. So there's a couple of specific vision diagnoses I want to talk about. What we were talking about above, so far up to this point, was when delays that you can expect with kids who have a visual impairment only and no other diagnoses. But often a vision diagnosis does come with other diagnoses. And so how it affects motor control in relationship to these three: retinopathy of prematurity, cortical visual impairment, and optic nerve hypoplasia, I just want to mention and go over a few things. So retinopathy of prematurity, the babies are surviving, right? They're being born 24 weeks and they're surviving. And if they're born that early, their lungs are typically not developed in their own oxygen. The oxygen can overvascularize the back of the retina. And the intervention is a laser, and it can be repaired. But if not, we have to be very careful with the retina detaching. So what is not uncommon to see, well, pretty much all the time with retinopathy of prematurity, is that the child is born premature. And cortical visual impairment is an area of the brain is affected, the visual cortex, so they're not really able to understand the information that's coming in. So it's not uncommon that there might be another area of the brain that's underdeveloped or has been damaged. So in both of the cases, if you're born premature, for sure, you don't have the physiological flexion at birth. When babies are born or starting in the 36th week or so in utero, they are pushing in this flex position against the mom, and they're building some strength and they're getting some feedback. And where they're born, they're in this midline flex position, and it gives them stability, and it helps them with their anti-gravity movements, right? Because they're already starting in the middle. And so they're able to move and explore a little bit more. So cortical visual impairment, sometimes too, the kids are with whatever diagnosis they may have as well, or born premature. And so if that's the one thing I just wanted to point out, if children aren't born with the physiological flexion, then that can be a disadvantage from the get-go. So premature babies often have low muscle tone. That's very difficult to move against gravity. They'll be in what people often describe as a frog leg position, the risk of plagiocephaly or flattening on the back of their head. So PTs, we always say midline, midline, midline is important. And what we'll often use for positioning is like a boppy pillow, those seat pillows around the back of the shoulders, so the arms are together around the legs. So they're in midline and they're in that flex position to help them with anti-gravity movements. If a child is born premature or has had a brain bleed or has had some underdevelopment of the brain, these kids may have a diagnosis of cerebral palsy as well. And that just means cerebral palsy is a very general term. It means having to do with the brain, and palsy is weakness or problem using the muscles. It is not a progressive disease not disease, but diagnosis. And what I mean by that is what's happening in the brain is not getting worse. It's not progressing. The presentation of a child, maybe they walked when they were little, and then as they got older, they may have tight muscles or some tight contractures, and they're just not able to walk anymore because they're bigger or for whatever reason. So it may look like it's progressing, but the actual reason for way their motor control is not progressing in the brain. So the primary motor cortex, our brains are fascinating. And there's an area on the brain that if a certain area is affected, you can expect to see certain parts of the body being affected. And there's different types of cerebral palsy based on the area of the brain where it's affected. So often on the left, where the pink is, we often see spasticity, which is stiffening or tightening of the arms and legs when they're especially with fast movement. You can have uncontrollable movements, and that's normally in the area where that green spot is called the base of ganglia. It can be the cerebellum that is affected, and so then you're going to have some balance or coordination issues, or it can be all over or diffuse, and then you really have mixed presentation. But the child in the first picture there is showing a diplegia, cerebral palsy, and it's described as diplegia, meaning that the legs are more involved than the arms. The one in the middle, one side's affected, not the other. And then the one at the top is a mixed or all arms, both arms and legs are affected. So if the motor cortex and the sensory cortex in the brain are affected, and then it's also that information from those two areas goes to the cerebellum. And the cerebellum helps it with the motor learning, sense of body positioning, balance and equilibrium, fine motor coordination. So the motor cortex, the sensory cortex is already affected, and then the information it's sending to the cerebellum then may not have that complete pathway or information that's of typical development. So that's going to be another factor how their motor control is affected. So spasticity is common to see with cerebral palsy, and it really is like a stiffening, or there can be an extensor tone, or if the kids are trying to move, they might arch their head and back. And one of the questions that the early interventionists often have is, I really have a hard time putting on a child's ankle brace if they have one, and they just really stiffen their leg. And so one of the things that I was sharing was, if someone has an extensor tone in their arms or their legs and they're stretching, if you bend the bigger joint, so in this example, if I'm trying to bend the ankle and I can't, I want to bend the hip and I want to bend the knee, then the ankle's going to bend as well. So sort of break up that extensor tone, the best way is to bend the bigger joint. If a kid is arching, you may want to help them get their head forward, and it'll kind of break up that tone. So if you need to put a brace on someone, or you have a kiddo that's laying on the mat that's really kicked in the tone and the spasticity because either they're upset or they're excited or they're really trying to move, you can give some rocking motion perpendicular, and that often will help them relax. And then you bend that hip and knee in this example where you're trying to put on an AFO. So optic nerve hypoplasia is a common diagnosis that we see. Where it crosses in the brain is sort of a regulatory center of our brain. The thalamus is there, hypothalamus, pituitary gland. So when kids have this diagnosis, I always want to know, are there other things? Do they have diabetes insipidus, where they have to regulate their water intake? Do they have any growth problems? Are they at risk for adrenal insufficiency, which can be a medical emergency? So we always want to make sure we're asking, are there any other things that we need to be concerned about if we see a child with this diagnosis? The thing that I wanted to point out, instead of the spasticity or the increased tone, what we see often with this diagnosis is hypotonia. And we see this in other diagnoses and sometimes just kids in general, where the tone it's just their body readiness, awareness, not, or body readiness is kind of more, kind of, for lack of a better word, kind of floppy. You can see by the pictures, their arms and legs are spread out. In the picture with the kiddo reaching for the ball, he's got to arch his head back for stability. Hypotonia can really affect a lot of things. The little girl, where it says hypotonia it can impact grip strength, speech and swallowing, posture, breathing, motor skills, digestion, stability, endurance, and overall mobility. And then you can see the different postures and positioning. So that's just something to take into consideration, that also is going to be a factor that is affecting motor development or motor control with kids with visual impairment if they have low tone as well. So that sort of sums it up. We really did talk about a lot of different things, but vision only, if it's a vision diagnosis only, that lack of movement really makes a difference on the sensory system, and because of the lack of motivation for vision, and it's just really this feed-forward system. So encourage the babies or the people that you work with that movement is really, really important, and it's really, really important from early on. So I thank you for watching, and if you have any questions, you can look at the last slide and there's somewhere to call or email. And thank you very much.